everyone, and welcome to Rad Chat, the multi-award-winning therapeutic radiographer-led oncology podcast. My name's Jo McNamara, and I'm joined by fellow host Norman John Anderson.
Hi everyone.
So we're here at UKIO. We have, drum roll, a physicist. Woo! Would you like to introduce yourself?
I'm Rob Richardson, and I'm a principal physicist working in central London.
Amazing. So there will be people out there who go, what's a physicist doing at a radiotherapy, oncology style conference? And obviously, we know that your role is truly essential to more or less everything we do. But for anyone who doesn't realise, can you explain a little bit about your role?
Yes, I suppose from a physics perspective, our job is very much all the background stuff. We kind of join the dots I kind of think about. I'm talking about physics with our planning team because you have the oncologists who see the patients and they prescribe, and you have the radiography team who deliver the treatment, and the engineers who look after the machines, and we're the kind of common thread between the three that kind of deal with all of those stuff. So we're kind of more scientific support, but joining those bits together.
Scientific support.
Have you practiced that?
You can tell I've been on a leadership management course, so I think that shines through.
What got you into physics?
I'll be completely honest with you, I fell into this profession completely by accident.
Everyone says that.
I actually wanted to be a doctor, so I did the classic biology, physics, chemistry A-level. I may not have quite got the grades to go to medical school, so I thought, well, what do I enjoy? Out of my 3 A-levels, physics was the one that I was most interested in. So I did that, went off to uni to do my degree in physics. I was doing pure physics.
Right.
And then actually my local head of radiotherapy physics, the local hospital in Hull, came and gave us a talk.
Right.
And I thought, that sounds kind of interesting. He did sell it quite well in that I didn't have to do some of the solid state modules. So I was like, sign me up for that. Changed my degree to be physics with medical technology, and then graduated and thought, this is something I kind of want to keep going with. It's better than being in a lab, better than just sat at a computer all day doing simulations, and was lucky enough to get on the training scheme, which is super oversubscribed, so I was very happy about that. And then
Which
just
seems bizarre,
progressed
because
through.
there is a national shortage, isn't there, of physicists?
There's a lot
in
of
this
people
field?
want to do it.
Right, okay.
There's not enough places funded to do it, unfortunately.
Right, okay.
When I was doing it, it was 3 to 4 people per place. I think it's even worse now. And then just progressed through, moved from Hull down to London to try something new, and moved around the London centres a little bit. That's how I fell into it. So it was never intentional. I wanted to be the oncologist, not the physicist, but here I am.
Do you regret your decision?
Not at all. Looking at their workloads and what they have to go through from the radiotherapy perspective, I'm quite happy in my little physics role. It's a shame we don't get as much patient contact. Normally when we appear around a patient, it's because something's gone wrong, the machine's gone down, or a shape change or something like that. So it would be nice to kind of be there for good things, but I'm quite happy with it. And I think I work in a centre where there's quite a lot of joined up between the kind of radiography, the oncology, the physics, so I do get to go down a lot more in positive circumstances than just, it's broken again and I've got a prostate patient struggling. That's how I got into physics.
Can I ask, in terms of like the role of technology, software, adaptive radiotherapy, there is looking like there'll be more of an integrated approach to physics dosimetry. Can you see your scope of practice
looking around
changing?
here, half the stalls are AI. It is a huge thing that's coming, but it actually leads to an interesting kind of dichotomy in that it's going to take away our work, which is good. It makes it more consistent, more kind of, I wouldn't say more safe, but less variable, and quicker and more efficient. But then you have all this skill set that's needed to support that, so then it creates another workload, and that's the clinical scientific computing, which is, if you think physics and radiography are understaffed, that is a workforce that has barely anyone in it, and most hospitals don't even have a clinical scientific computing department. So I think it'll be revolutionary for patients, but I think as a workforce, there's still going to be as much work. It's just going to shift what that work is into that technical sector. And part of my job actually is looking after the IT infrastructure in radiotherapy, so like our RAS systems and RMV systems and things. And I was never trained on that. I was a physicist, and it was like, here's write some code, write some script, look after this server farm, and I'm like, yeah, no, sure. Google this, Google that.
YouTubing.
Yeah, I mean, absolutely. It's completely self-taught. But we now have clinical scientific computing staff coming through who are a godsend, thank God, who know these terms, and I don't have to keep Googling on my phone in meetings. What does this mean? Oh, yeah, no, I've heard of that. Yeah. But yeah, I think it is going to revolutionise massively.
What's your favourite part of the job?
I think my favourite part of the job, and this is going to sound really bad, and I know everyone in Pure is going to absolutely go off when they hear this, is I really like being on the machines, so QA and kind of just like being down on the floor, whether it's kind of things
It's
like...
because you get to work closely with us,
you know,
isn't
raiding
it?
the cupboard to the suites and things. No, but I think...
Do we give a better conversation? Is that what you're saying?
I mean, I wouldn't want to go down that level. But yeah, I just think it's really nice to be downstairs. There's patients around, there's radiographers, there's physicists.
Chocolate.
So doing QA, although it can be quite dry, is quite nice. Whereas like some of my other work, which is writing code and script, and just sat at my computer. Well, it's not worked. You know, and the development stuff obviously is great as well. I think as a profession, radiotherapy moves very quickly, even compared to some of the medical physics specialisms. So we get a lot more bits of kit, a lot more innovation that we can really drive forward with. So I think, yeah, being on the machines is probably my favourite part, but also developing those new things and seeing that benefit for our patients and staff.
So in terms of kind of the role of physicists, where do you see yourselves kind of changing in the future, or potentially even just you yourself? Where do you want your career to take you?
Oh, now that's a question. I have developed quite an interest in the digital side because I was kind of expected to do it, and it's developed into my job role. So personally, I think leaning into that and how that can be used, and things like I was saying about the clinical scientific computing, that not really being understood. So one of my roles at the minute is to try and develop that within my current department. So I think that's probably where I'm leading, is actually saying AI is coming, cloud computing is coming, we need to develop that skill set, have leadership in that field, and bring that into the radiotherapy workforce. I think that's where my career is going. And I think we're going to see more of that within the general, because it's not just me who's working with these cloud-based systems, it's going to be you guys on the treatment floor, it's going to be our planning team, so they need that skill set as well. So I think that's where a lot of it's going. And planning systems, things these days have a lot of coding and scripting, so IT skills basically I think is the future of all of our workforces.
So how, can I ask you a controversial question? With all of this going forward, and we always get machine breakdowns and cloud things going down, IT servers not working, how is the NHS going to keep up with all this?
So the NHS, I think, needs to really embrace this and needs to get on board. There was the UK government position statement that you should go cloud first. You have to show why you haven't gone cloud first. And I think it's going to be a case of just lump it and get on with it. And there are real benefits. There was an IT issue in Ireland recently. All of their radiotherapy centres went down. They lost RA. They didn't even know who was on treatment. They had to put a local news alert out saying, please call this number if you're having radiotherapy.
Oh my God.
We don't know who you are, what site, what your oncologist is, and then their oncologists were kind of going, I think it was a prostate, and maybe there was some nodes. If we'd had cloud-based, we'd be more protected to that and more robust to that. So I think we have to embrace the challenges because we have such benefits from it. And big data, population studies, looking at all that kind of stuff, I think is a real future again of our thing. I was working recently with NHS England on a Prono project, so looking at the dosimetry across lots of centres, and are there centres that are really leading the way, and can we learn from them rather than that kind of classic postcode lottery situation.
I totally get what you're saying, but I also know going into a department, there are some departments that don't even have Windows 10.
Yeah.
Like, how is the NHS even going to afford to be able to make changes?
There's two areas of the NHS that they need to work on, IT and data protection.
Yeah.
And they're not radiotherapy centres, services, but they have such an impact. I won't say how long, but it was more than 12 months. It took me to get through data protection to have Prono in place in my trust. This was an NHS England sponsored project, and I was not the first person doing it. That kind of blocker is going to make all of us go, I can't bother to do that.
Yeah.
That needs to be dealt with, and there needs to be some central investment in IT, data protection. That skill set needs to be there.
But isn't it strange how COVID allowed so much
Microsoft
change to happen
Teams straight away, overnight,
rapidly?
everyone's using it. But then something else that's very niche, no. And I think it's really selling the profile of radiotherapy and saying, well, these things going quite quickly elsewhere, why isn't it happening in radiotherapy? Are you aware of radiotherapy, aware of what this can do?
Yeah.
That's
People
my
aren't,
opinion.
people aren't aware. So we work with Radiotherapy UK. We went to Parliament to talk to MPs. They didn't really care about what we were saying. To them, listening to the London boroughs, they were like, oh, well, my borough is under the limit, which is 20% referral rates, but actually it's still 15%. It's still not that great. It should be 0% delays and stuff like that, but it's going to take a while for investment to just...
Yeah, I think across all of our... It's quite nice actually here today, IPEM, site radiographers, they're all together on a stand, and I think it takes a real joined up effort to say, this is radiotherapy, this is what we do. 40% of cancer treatments have radiotherapy, yet we're, 5% of the cancer budget, or 7%, or something like that?
Yeah.
It's really interesting, somebody can say, oh, there's this chemo drug that costs 100,000, 10,000 per dose.
Yeah.
Yes, let's do it. It gives you 10% more. Oh, radiotherapy can give you 20% more at 400 quid. No, it doesn't matter, we don't care about it.
Yeah.
It's really selling the profession, selling what we can do. But I think that starts within our interests.
Yeah.
We had a recent issue where it was a study of lung chemotherapy, but they needed to look at some data from radiotherapy, and they almost kind of not gave up, but thought that getting the radiotherapy data would be really difficult. Somebody's going to have to go through and get it. And we were like, we have that skill set. We can script it. We can code that. We can give you that. We weren't even selling it within our own, what we can do within our own department even. This was a radiation oncologist who wasn't even aware of this. Never mind the trust level. So I think that needs to be pushed forward. There is a scheme, I don't know if you're aware of the HST scheme with physics. They're trying to get more kind of clinical scientists at board level, and I think that needs to keep going and across the professions. Why have a chief nurse but not a chief clinical scientist, not a chief radiographer, not a... why is one siloed against the other?
Yeah. And it almost does create that competitive element, doesn't it? It's bizarre, when actually it should be collaborative, integrated. Recently, IPEM, just this week actually, brought out the workforce kind of plan and also talked about the fractionation statistics. So the fact that that was going to massively increase how many fractions we should be doing every single day, which just isn't achievable. What would you say in response to that? For any strategic leaders out there?
The interesting, fractionation is a classic thing, and this came up during COVID. We were disincentivized from having short fraction treatments because of payments.
Yeah.
It astounds me that still this model, when actually we can treat a breast in 5 rather than 15, but we'll lose money. Why is that? There's no joined up thinking between those kind of things, but obviously even if you did deal with that, there's going to be more patients, there's going to be an expanding workforce. It comes down to the classic thing of more money. We need more staff, more machines. We need a better understanding of it as well. There's no forward planning. We'll give you $1 million now, but we know in 10 years you're going to need a replacement, but we won't think about that. We won't plan for that. We'll deal with that in 10 years' time. Even something as simple as we were looking at a system recently where we could either buy it internally and pay a lot up front, or we could kind of rent it, basically cloud-based.
Klarna. Did you do Klarna?
We could Klarna an R&V system over 10 years, but as a cloud-based system, so what do they call it? Software as a system or service or something. But that was every year, and it was I was basically told, it'll be easy to get the $1 million now because it's one financial year than 250 every year, because that's looking in 4 years' time. We don't know what's going to happen in 4 years' time. It's like, but that's the better system. Like, I shouldn't be swayed by that. But yeah, it is, unfortunately, it's one of the few things that many, but then AI, those kind of tech can create efficiencies to absorb some of that, but it's not going to absorb it all, unfortunately.
I feel like we need to get you back on, Rob, for a proper episode. It's someone who walked past there and said, no, I don't want to come on
the one thing I can do is talk a lot. I just don't like hearing myself talk a lot.
You don't have to listen back to it, just all your colleagues will listen in the office.
I'll send an email in a sec.
Oh, it'll be on they'll put it up. They'll put it on the wall, probably. They love it. I have a great kind of collegiate environment. Like, everyone gets on really well in my department. It's quite nice. It's great physics. Shout out to Imperial Physics.
No. Well, we're massive fans of all of the physicists, dosimetrists, everyone working in radiotherapy. So thank you for coming on.
Thanks
and
for
hopefully
convincing.
speak to you soon.
Thanks, guys.